But we have Klaus, Dr. Pors. Please, go ahead.
Okay, thank you. Sorry, I was looking for how you actually activate a hand here, and I struggled a little bit. It was sort of hidden at the bottom. I really like that presentation. There were lots of really interesting things to discuss and sort of think about. So obviously, as we discussed a little bit earlier on, there's a lot to learn about immunotherapies, and here you are proving that there's some links that we can exploit. I was interested in this sort of long-term effect, and I know you haven't got the answers to this, and we can speculate on it. So the NOTCH pathway is obviously also one that is very interesting, the stem cell, and you refer to these memory stem cells. But NOTCH is also, if you inhibit it, you have an impact on, there are different types of cancer stem cells, and it depends on the cancer type. I wondered whether you could speculate a little bit on whether, when you try to intervene NOTCH1 or NOTCH pathway, what are the implications of eradicating what I would call a malignant stem cell, not one that is protective. And it's a very fine-tuned balance between the two, I guess. Is that something you could speculate on?
Yeah, I think so. So indeed, in the lab, we are working on basically both strategies. So we have strategies that inhibit NOTCH1 and strategies that try to stimulate NOTCH1, like the one that I presented today. And the important thing about NOTCH pathway is indeed the selectivity. So in order to have a NOTCH-based therapy, we need to ensure that this therapy has a very good selectivity. So for example, today I showed that we tested this drug also on cancer cells, and we don't see modification of NOTCH pathway in cancer cells, meaning that this regulatory axis is not present in the cancer cells, but probably more in the immune components, so it has a good selectivity. However, it's also true on the other side that we, when we use NOTCH inhibitors, then those are effective in basically reducing the growth of cancer stem cells, for example, in breast cancer. But again, one of the main side effects of these compounds is also that they suppress the immune system. So it's always the case of trying to improve these NOTCH-based therapeutics so that they can be selective for either the cancer cells when we want to inhibit NOTCH1 or the immune component when we want to stimulate immunity.
Okay. Yeah, I think that's I think that you're right there. Can I just is a technical question. You had these patient-derived organoids. Do you use these? I mean, I don't know how you reproduce it, because once you have used them, they're not like immortalized cell lines. You use them once or twice, and then is that it? Yes. So do the data from your different organoids then, are they very similar? Because obviously they come from different patients, and therefore I wondered whether they respond in various ways or they're very consistent.
Yes, so one thing, because we are working on immunotherapy, so of course, depending on, let's say, if a tumor has a lot of immune infiltrations already, probably in the organoids, you're going to have more T cells, and so you are going to have a better response. And instead, the tumors that are more or less, they have less immune components, then we see a lower response. However, this in a patient would not be a problem, because we aim to stimulate the systemic immune response. So in theory, more T cells should be recruited to the tumor microenvironment and be more effective.
Okay, all right. Thank you.
Thank you for your question. Thank you.
Okay, nice discussion.